Thank you very much, Heather. Today, what we're going to talk about is diabetic macular edema. Diabetes is one of the major causes of blindness, particularly in the age of 50 and over, and specifically type 2 diabetes. Next slide, please, Heather. And we'll go to the next. So the objectives that I'm hoping that you'll get out of this are, what are the risks for diabetic macular edema? That is fluid buildup under the layers of the retina due to diabetes that's out of control. We want to look at the complications that are associated with diabetic macular edema, and also the retinal changes that occur as seen on the digital imaging that we have today, called ocular coherence tomography, or the short form of OCT. And then finally, what can we do to protect ourselves so that we don't lose our vision, one of the most, if not the most important sense, particularly throughout lifetime, that so defines your quality of life. Next, please, Heather. Next slide. Yeah. So what is diabetic retinopathy? Well, diabetic retinopathy is when the sugar levels are the glucose levels are too high. What happens is that the blood vessels at the very back of the eye become very fragile. And these blood vessels burst. And when they burst, they spill body fluid, that would be blood, all over the back of the eye, the retina. And then when that body fluid, or blood, if you will, starts to reabsorb, now, as like in a scab, it starts to kind of shrink the tissue around it, lifting off areas of the back of the eye, the retina, and sadly, in the most central area of vision that's most critical for vision, which is about the size of a pinhead, the macular area. And when that happens, we start to lose vision. First, it becomes distorted, vision becomes hazy, and then we have a problem. Next. So again, macular edema is when fluid, which would be blood, and various deposits of protein from that blood accumulate in the central area of your vision, much in the same way you hear about older folks going to the ophthalmologist to get a shot in their eye to prevent the bleeding. That is bleeding macular degeneration. It's really the same effect. And in fact, the treatment is exactly the same. And now we have a way of, when we can detect it early enough, to inject a substance in the eye to sclerose, or to shrink the blood vessels so they don't bleed. And so when you hear about people going to the ophthalmologist's office, they're going there because we have bleeding underneath the retina, either due to macular degeneration that's bleeding, but in many cases, a diabetic retinopathy. Next. One of the easiest forms for a person to determine whether vision is changing is so simple that it's almost hard to believe that it's diagnostic. And that is what we like to give our patients, a little grid called the Amsler grid. You don't have to remember the Amsler, it's just a grid. So when people look at the center dot out of the corner of their eye with their glasses on or off, depending on which way they do it, and they look at the center dot, they will see that the squares are somewhat distorted in the center. This indicates that that central area of vision that's most critical to your seeing has been affected catastrophically in many cases. Next. So if you look at the macula and you see on the right side what we see as a normal retina, and that is macula you see with a very central area called the fovea. That's a part of the eye that's the size of a pinhead, and if you're crazy enough to look at the eclipse, you burn a hole in that area and lose all of your central vision. But when you're looking at the right side, you see macula, you see fovea, and you see the two blood vessels around it. That area between those two blood vessels is the most critical area of vision. If anything happens in that area, you are in big trouble. So when you're doing that grid, you're checking that central area of vision. So when you get your eyes examined, you should ask whoever you're seeing as your eye doctor, exams or grid. And if you cannot find it, then all you have to do is simply just ask them for it or go online and make your own. Now, you see on the right-hand side, you will see in between those two blood vessels where we had written on the left-hand side, macula and fovea, you will see scar tissue, the white area. You'll see some bleeding there. And then if you go underneath that, you will see what is considered the edema or the swelling on the very top picture. That is what we see in the ocular coherence tomography. We can see the piles of fluid underneath there. It should be like the picture underneath it, a flat. And so our objective is to get the blood out of there. Then the vision will become better and you, of course, will see better. Next, please. So how common is diabetic retinopathy and what are the risk factors? Let's look at it next. Diabetes, if we look at the Canadian population, I'm not sure if these are recent statistics or not, at 33.7 million, probably about 8% of those are diabetics. Most of those are over the age of 40. In other words, a type 2 diabetes, which really is due to gaining weight, not eating right, not exercising, and probably eating the same food you did when you were 15 and now you're over 40. Probably not going to work anymore because you're not going to burn it off. Diabetic retinopathy is the end stage of diabetes. That means that you've had diabetes for some period of time, probably uncontrolled. And of that 8% of the public, it is probably about maybe 25% that are really in very serious cases. So when we get diabetic retinopathy and there are various stages of it, you're in serious condition and you've had diabetes probably controlled or uncontrolled for some period of time. So how common is it? It's pretty common for those diabetics who do not keep what we want. An A1C, that is when you go to see your family doctor, they will give you an average in your blood work of your glucose levels for a period of 3 months. You should have that A1C sitting around 6.5 if you're an adult. The reason behind that is if it goes certainly into double digit, you know, Christmas is coming. So we've got the shortbread cookies, all that white material like pasta and bread and all those things. Now where the pancreas has to convert has to use so much insulin to digest it, it causes the sugar levels to go really high. That is what you want to avoid. So diabetic retinopathy, when you get to the picture that you're seeing on the right-hand side, where you have the scarring, there's nothing that we can do. Unfortunately, it's like cutting off your leg. Once your vision is gone, it's gone, and it's gone permanently. The sad fact is, if you come in for a regular eye health examination, and I would suggest over the age of 65, it's covered once a year by the government anyway, so why wouldn't you? If we detect it in the early stages when it's still bleeding or not calcified into these scar tissues you see in the right-hand side and the white scarring, before it gets there, then we have some hope. Next slide. So what are the risks of diabetic retinopathy? Well, we've already said that, you know, getting a high body mass of over 27 is a problem. The other is not controlling your sugar levels and what you eat. So my general rule of thumb for people that aren't, well, what you shouldn't eat would probably be something like any starches. They're really bad. So I always say to people, if you're not sure, avoid anything white. That's probably your first starter. Keep your blood pressure under control. A normal blood pressure is about 120/80. When your blood pressure, particularly the denominator, the bottom one, gets higher than 100, you're in serious trouble. Because again, as when diabetes, what you're going to do, and diabetes and hypertension sometimes come hand in hand, because usually it's people that are overweight. And so what ends up happening is that, you've got the diabetes, that will cause fracturing of those central blood vessels. And then you have the hypertension that will cause the same thing. So together, it's a recipe really for catastrophic visual disaster. And then what happens? Well, if you don't get the diabetes under control and get your A1C to 6.5, what ends up happening is that soon you start getting gangrene of your toe. It turns, or different limbs, they start turning black. Well, then you have to amputate your leg, your toe, or whatever. And then, of course, your kidneys go and you're stuck in dialysis. That's the end thing. Who wants to do that at the end of what we might say a series of life? So I always say to people, look, take care of it now. So that you can have enjoyment in the final stages of life and not sitting in an ophthalmologist's office getting a shot in your eye to prevent the bleeding, and also then having to go to dialysis and sit there and wait or get on the list for a kidney transplant. Next slide, please. Also, make sure you keep your blood pressure under control. That's also a very important thing. And, people say, well, I'll go to the drugstore and get my blood pressure checked. The problem with that is that A, it's not convenient. B, is that cuff, if it doesn't sit properly all around your arm, doesn't give you an accurate reading. So, if Christmas is coming, if you want to get a gift, why don't you just tell your family, get me a blood pressure monitor at home, and then you have your own cuff. You have your own reliable instrument that you're comparing to over and over again. You can write it down, you can pair. And I just want to say one thing. The most important thing is to avoid a stroke, of course. So the most important time to really take your blood pressure is before you go to bed and then first thing in the morning. The majority of strokes occur within an hour of waking. So you really want to know what your blood pressure is the night before you went to bed and first thing in the morning within an hour of waking. That way you can see whether or not it is controlled. So that's just a word of thumb to really prevent a stroke. No one really needs that. Next slide. And we'll go to the next there, Heather, please. So, and you can just keep going on this, Heather, as we populate this. So the key thing is to see your family doctor on a regular basis. Keep your sugar levels under control. Know what they are. Keep your blood pressure under control. Eat properly. All the things that we hear about over and over again. Have a complete eye health examination. I would suggest once a year, which is covered by the government as well. So there's really no need for not coming. And how important is it? Well, the old adage where if it ain't broken, don't fix it. We should throw that one out with the last decade. And that is, how do you know if it's not broken? And by the time you want to get it fixed, we're way past the point of where we can do anything. So if you think about how important is your vision in everything that you do, everything, well, and it's not replaceable, then it's something we really want to take care of. Next slide, please, Heather. And we can just keep going on that. So we'll let this one populate, and I'll just go through a few things on that. So we have two types of diabetes. Of course, we have a type 1, and those are people that are, children that are born with diabetes, almost. And so they usually take insulin right off the start. And then they're the most common, which we already know is really getting worse, not better. And that is the type 2 diabetes, which is really based on, eating the wrong food, genetic predisposition for diabetes, various things like that. So we need to exercise. We need to eat the right food. We need to avoid starches and things that increase our insulin levels. to a level that's really too high and cause the pancreas to go over time. Also, probably the most important thing is a routine eye health examination. If you're 65 and over or a diabetic, once a year, you should be in. Please, next slide, Heather. Again, yes. So what are we looking for when we check someone with diabetes? Well, first of all, we want to look at the history. We want to see how long, what medications they're on, how long they've been a diabetic, at least in their own perspective. Also, what we do now, of course, is ocular coherence tomography. It takes a scan of the back of the eye. Thank goodness for AI in some respects, about 25,000 scans a second. It allows us to go deep into the tissue of your eye to see if we've got anything, as you see on the right side. And that's a pathetic case. That's a case that's been around for a long time, and that person would not have any central vision. In other words, they would look at things they were trying to read, all of the central vision would be completely obliterated. So it'd be like you could see kind of off to the side, but nothing centrally. So again, that's the worst case of what we call diabetic retinopathy, where nobody can help you. You are like that for a lifetime. And here's the sad part. You didn't have to be. Let's do the next slide, Heather. So you can see the bleeding underneath. You can see on the right-hand side diabetic, and you can see the blood on the periphery, like this huge pile of blood. You can also see between, remember I told you those two blood vessels, you see the white star, that is also a scar tissue. But you can see that little red cherry in the center between the two blood vessels is still pretty good. So if we can, this is a case of where we would probably send you off to the ophthalmologist immediately. And what they would do is give you an anti-VEGF drug, a shot in your eye with the needle. And this drug, actually, it's kind of interesting, off-label. It was used as a colorectal cancer drug. We found that with people that had colorectal cancer and where they were trying to sclerose the blood vessels of the cancer cells and shrink them, they actually improved in vision. So off-label, it then was used as Avastin, which is now reused again at $50 a shot. But a few years ago, of course, all these pharmaceuticals take that particular drug and they make it into a drug of a smaller molecule called Lucentis, or a little bit cheaper, Aaliyah. And that drug was $1,500 a shot, as opposed to $50 a shot, which was the Avastin. But now, with healthcare cutbacks and all the other stuff, we're back to using Avastin again. So the question is, does it really make a difference? The truth is probably not. Maybe in the early stages of getting an injection in your eye, the smaller molecule would be better, but in the long run, probably the cheaper one, the Avastin, is probably just as well. Now, I want to tell you, we've come a long way in treatment, because in the early days of where it was long ago, it was catastrophic, because what would happen is that we would have to use a laser and burn off those blood vessels. But wherever you use laser, you burn a hole and you're done. So it used to be in the 1970s and 80s of where I come from, when we'd send a patient for bleeding on the retina, the ophthalmologist would use a laser and zap off the blood vessels. So when they saw me, they could still see. When they came back from the ophthalmologist, they couldn't see a thing. So try to explain to a patient that was effective healthcare. And you can see what diabetes looks like in the bottom left-hand corner. That's kind of what you'd be like. It's like you can kind of see parts of things, but it's like me trying to drive away in the middle of winter, and I don't want to defog my car because I've got time. So I've got this little patch that I can see through. The rest of it's all foggy. That's kind of what it looks like. Next slide. So again, this is well, we'll go through a couple cases just so you get the drift of diabetic macular edema. So again, you can see that this patient has had diabetes for some period of time. You can see the white area, and that is scar tissue. Next. And is there evidence of diabetic macular edema? Well, certainly there's evidence, because you can see the scar tissue. That would only happen if blood has been there and is now turned into into heart exudates, as we call them, or scarring. So we have the case of good old Sylvia, who's like 50 years of age. She's a type 2 diabetic. And so we're going to do a little test to see if you got it or not. Her visual acuity is not bad at 20/50. Her blood pressure, remember I said 120/80 is good. So yeah, that blood pressure isn't very good, as you can see. And she complains of vision loss in the left eye. So let's go to the next slide. So we do a variety of tests. We're going to do an OCT on her, and we're going to put drops in her eyes. We're going to have a good look at her retina. Next slide, Heather. What do we find? Well, is there any evidence of diabetic macular edema? Well, I'm sure hoping you'll say yes, because certainly there is. You see the white exudates there, meaning that scar tissue. You can also see a hemorrhage there. Next, please. And next. And you can see on the OCT, this huge elevation, it should be flat. Next. And this is what we look like in the final stages. And when we look at something like this, we have there's just nothing that we can do. This is pretty well the end spectrum. So your central area's vision is gone. You've got a big black hole. The only way that you can see is kind of peripherally off to the sides. That's a tragedy. That's what it ends up looking like in the final stages of diabetic macular edema when it turns into scar tissue. Next. Again, you see the pile of fluid with the ocular coherence tomography. So it's really important if you're diabetic that you actually see someone who has this technology, because that way we can compare you to yourself in perpetuity. Also, if we have to send you to a specialist, we can download this information. We now have various telemedicine portals and sites where we can download the information and send it directly. We don't print it out or fax it or anything, because frankly, it wouldn't fax or print out anyway. But this information we can send digitally, and then the ophthalmologist can see it right away and get you effective treatment as quickly as possible. Because the whole objective here is we want to get rid of that fluid that's causing the lifting of the tissue, because the longer the fluid is there, the more visual cells die off, which cannot be regenerated, and the less of a chance of restoration of vision. Next, please, Heather. Yeah. And so here's Heather's retina, and you can see the blood underneath there. Keep going. And again, this is a normal retina in the macular area. So remember, as I mentioned to you, the macular area is the most critical area of vision. That, if you lose your macular area, you've really lost your quality of life as far as seeing goes. So that's the area that you want to protect, really, with everything that you own. And that's when we do that crazy little Amsler grid, you're checking that particular area. So when you get your eyes examined, make sure, even if you're perfectly normal, make sure that you get one of those grids from your family optometrist, because it's probably the best little crutch that you can have to check your vision, even regardless of any age, as to whether there's a change, because that critical area of vision is really something that we can't salvage if something goes wrong. And we want to know if there's any changes as soon as possible. So if you look at a normal retina on the OCT, the ocular coherence tomography, you can see the central area, that little dip in the center, which controls your central area of vision, is about, in terms of measurement, 250 to 280 microns. That's kind of what we want. Next, Heather. And again, you can see when we do fluorescein angiography, sometimes when you're diabetic, and we want to determine what areas that we need to treat, we will inject a dye called fluorescein in your blood vessels. And what happens with the blue light is that with fluorescein, it will fluoresce. In other words, we'll be able to see how big a mess. It's kind of like doing an X-ray or a radiogram of your eyeball. We can actually see where all the blood vessels are and what state that retina really is in. And that's when we inject fluorescein into your bloodstream. And then it fluoresces under blue light, and we can see that this is pretty bad leakage of blood vessels. Next. So again, this is the fluorescein angiography of this particular sylvia. This is not good vision. It should be all clear, as you see in the very edges of this picture. That's how it should be in the center. I can tell you that good old Sylvia, only 50 years of age, really has no usable vision that one would consider appropriate in her right eye, and in that particular eye, and that's the left eye, and that's actually quite disturbing. It didn't have to be that way. Next one, please. And keep going there, Heather. Okay, so again, what is our role in the management of diabetic retinopathy? Well, I would say that our role, I hope that is education. That is, we want diabetics to come in on a regular basis so that we can do an OCT, we can check their vision, we can get them at a stage that is preventative. Plus, we can talk to them about how they should manage their diabetes, and if they're not, why it's important. We also can file now we have everything digital, so we can have a permanent record of themselves, that we can compare themselves to themselves in perpetuity. So if we have to do a little bit of education because, you ate too many of those cookies at Christmas time, and good old Santa Claus, I'm sure he's in bad shape these days, eating every single cookie he came to that was left on his plate. I don't know. Maybe we should be giving Santa some coal or something. I don't know. Rather than a cookie and milk. That's probably not good for his diabetes. But anyway, I'm just saying that we have to really watch what we eat. Next one, please. And again, just keep going there, Heather. Yep. So let's look at the treatment. What can we do about diabetic retinopathy? Go ahead, Heather. So remember, I was telling you that in the olden days, we used laser. And frankly, that's still used today if it's out. And remember, I showed you the central area of vision between these two blood vessels are the most important. Now, if we have bleeding on the outside of those blood vessels, we probably will still use laser today. The idea of the laser is what it does is when the laser hits the tissue, it actually burns it or it photocoagulates it, and it will stop the bleeding. So, for example, if you're having veins removed on your leg or sclerosed or getting rid of pigment spots, really what it does is it just destroys the blood vessel, and then you won't get any further bleeding. That would be the ideal treatment on the outside of those two blood vessels. But anything in between those two blood vessels, we cannot use laser, because remember, wherever we use laser, we burn the tissue and the tissue is gone. Now, sometimes it's such a mess inside the eye that we have to get things under control so we can actually see what we're doing. So we'll give you an injection of steroid in the eye. Let me tell you, it's not pleasant, and it's not really done much today anymore. I guess it still is in some circumstances, but that's when you really got a mess. And the idea of a steroid is to prevent the body from fighting against the tissue. So in other words, you got a spill of blood on your retina, and we know that the body is going to say, well, I got to fix this. So what it's going to do is start growing more blood vessels and scar tissue to try to fix this spill of blood. And of course, when that happens, that makes the situation worse, because it contracts the retina and it pulls on the retina, pulling things apart. So that's why we have to give a steroid injection to the eye. And anybody that's had it, trust me, it's not pleasant. You will have, you'll be seeing floaters in your eye. It's like looking through, how shall I say, driving in a blizzard. You've got areas where you can see, areas where you can't see, and that will last for some period of time. So the most common way today is if we see any bleeding underneath the retina, as we showed you in the one picture, then what we'll do is we will download your information, the OCT, the pictures, all the things that we need, send it directly on a telemedicine portal to a group of ophthalmologists that are retina. I do want to tell you, when you see ophthalmologists, people think, well, I'm just going to an eye doctor. That would be us, or that would be an ophthalmologist, it would be a surgeon. But I really want you to understand that it's most important coming to see an optometrist, because we can send you to the right ophthalmologist. There are ophthalmologists that do retinas only. There are ophthalmologists who do glaucoma only. There are ophthalmologists that are general ophthalmologists and do a spattering of everything. There are ophthalmologists that just do the cornea, and so on and so forth. So there are ophthalmologists that treat dry eye only. So the key thing is, by seeing your optometrist, we will be able to send you to the right ophthalmologist. In this case, it would be retinal, to get in very quickly. So that's why it's really important to come in and see an eye doctor for an eye doctor problem, rather than, say, even your family doctor, who may not know. And when we've got all the evidence, and because we have the equipment, that's all we do, and send it via telemedicine portal, you're going to get in quickly, because the ophthalmologist sees already what the diagnosis is and knows what the treatment is, as opposed to going through your family doctor who's not sure, doesn't have the equipment, and the waiting period could be long. Remember, when you have blood in that particular area of your retina, it is critical. Really, hours matter that we get that blood out of there, or do something about it, because we don't want it to turn into scar tissue, and because we don't want vision to be obstructed that will never come back. So as I mentioned to you, the anti-VEGF drugs that is shot will be given into the eye with a big long needle. It's pretty scary. The idea is that we inject this medication into the eye, and what it will do is sclerose the blood vessels. And Lucentis was used for some period of time, put out by Novartis. However, that drug is so expensive. The shot is probably about anywhere from $1,200 to $1,500 a shot. And the one they started with many years ago was Avastin, and Avastin is still used today. In fact, it's coming back at $50 a shot. So, you don't know about it until we actually use it. So the difference is really probably minuscule versus the cost. So I just want to say that the key thing in treatment option is to get in very quickly. And once again, if you're a diabetic and whatever, and you've got your Amsler grid, you will be able to tell whether there's a change and get in quickly. So that little grid, make sure you get that when you see your eye doctor. Next slide. So I've already gone through laser treatment. You see all in the bottom right-hand corner, you see all those little spots. Those are all burn marks from a laser. And that's loss of vision. You won't get it back. Next slide, please. And again, steroid treatment, you see all those little X marks. Well, basically, that's what you're going to see. You're going to see all these floaters all over the place. In other words, it'll be like there's one of those little snowballs where there's Santa Claus, you can turn it upside down. You see all the snowing. That's kind of how you're going to see for probably a couple months until things get dissolved. So it's not pleasant. Next slide. Okay, now we've got good old Catherine, who's 64 years of age, and she's a type 2 diabetic. Let's see if you can answer this yourself. Her A1C is 7.4. Not bad. 6.5 is where we want to be. And she was diagnosed as a moderate diabetic macular edema. So she's had 2 laser sessions. Her vision, not bad at 20/40. And, it's stayed pretty much about the same. Next slide, please. Well, let's take a look at you see all that laser treatment, you see all those holes that are burned. Oh man, it's hard to believe that she can actually see as well as she can. But if you'll see in the very center of all that white halo, in the very center is an area that's still untapped. That, the size of a pinhead, is actually giving her half decent visual acuity. Next slide. So again, the controversy is out there. Should we do Lucentis, which is $1,500 a shot, or Avastin at $50 a shot? The truth is, Avastin is off-label. It's a colorectal cancer drug. However, the effects are virtually the same. So, we have to cut back, and people are getting older, and well, I don't know. The situation is such, we're running out of money. We got to pay for all the COVID expense, I guess. So Avastin is now commonly used again. And, is it really dangerous to use? I don't think so. I think that now we're going to have more peer-reviewed studies saying that the effectiveness is pretty much the same. It's just that Avastin is off-label. It's a large molecule. Lucentis is on-label and been approved by Novartis. And of course, they have to pay for all the approval and FDA stuff and so on and so forth. So now, like I said, it's much more expensive. So whether it's Lucentis or Avastin, I don't know. You may want to talk to your ophthalmologist on that particular one. But I think now you'd have to pay for Lucentis out of pocket. And I'm not sure there'd be a big difference. Next slide, please. What's interesting, though, if you look at this, the change in visual acuity and in retinal thickness. So if you look at Lucentis is the green line, and I should say Lucentis is the orange line. Lucentis and laser is the green line, and then laser only, which remember in the 90s all we have was the bottom line, the blue line. You can see that now with these anti-VEGF drugs, what a difference we've made in visual acuity and the importance of visual acuity. So from starting at 0, poor visual acuity, you can see how the vision is improved with the use of Lucentis rather than just the laser at the bottom one. And you can also see the swelling that has gone down as well. Again, let's take a look at the green line with both laser and Lucentis, but just with Lucentis alone, the anti-VEGF drug, you can see how the swelling has gone down compared to what it would have done with just laser. Next slide. So again, when you're getting an anti-VEGF drug, you're going to be seen over a period of time. The first 3 months are the most important. So the injections are usually given about 3 consecutive things. Some it depends on the surgeon. It depends on what you've got for fluid, but usually they're spaced out a month apart. Next slide. And we'll go to the next slide so you can see what happens there. And again, we have Catherine take a look at before, when she came in, there was before the treatment of Lucentis or an anti-VEGF drug. And then you can see how the swelling has gone down after the treatment. Pretty remarkable, actually. And patients will find their vision will unbelievably improve. Next slide. And the next, just keep going there, Heather. Okay, so we have Charles here, who's 62. Let's see if you can actually do this as well. His A1C is 7.1, not bad. Visual acuity is 20/60, not bad. Blood pressure, well, a little sketchy there. 170 over 110. Remember, you want 120 over 80. Next slide. Well, do we have any diabetic macular edema? Yes, we do. So Charles has not been a good boy. He's been eating too many sugar cookies because you see that there's some atrophy, some scarring. Next slide. Well, not good. You see how it's swollen there with piles of fluid underneath there. Next slide. And you see that central area that's a little bit darker. Charles, you're being a bad boy because right around we don't want anything to happen in the middle of that little dark spot, because if there's any bleeding, you can see the end of those tips of the blood vessels from fluorescein angiography. You can see how we've got some, some leakage there. So he's got to be very careful. Next slide. Well, so what do we as optometrists, what role do we actually place? Well, as you already know, to get a referral to an ophthalmologist, well, if you're going to try yourself, you may as well not even start. Going to your family doctor is a little bit better, but still not very good. The best role is to come in and see your optometrist on a regular basis. And don't wait. If it ain't broken, we'll fix it when it's broken. Don't wait for that. You want to make sure that the most important thing to your independence in your life, to your quality of life, and everything that you are is your vision. And remember, unlike teeth, which you can replace and spend a lot of money, vision you can never replace. And once it's gone, it's gone. And I know you probably heard in the news the other day where somebody transplanted, I don't know what country it is, an eye. And they actually had the eye working. Well, no, they didn't really have the eye working because the eye is an organ, like the heart is an organ, but it couldn't process anything because the eye is part of brain tissue. So you might have the eye alive, but different than anything else is that cable called the optic nerve that transmits everything you see from that organ into your brain to be processed. So, okay, you got an eyeball that's actually moving and got blood flowing through it, but the nerve connection has gone. So someday, maybe in the future, I don't know, we'll be able to transfer an eye when we can transplant a brain. Can you imagine if you had your original eye and then you had somebody else's eye who processed things differently? Can you imagine how confused you might be? Anyway, just food for thought. Next slide, please. So we have type 2 diabetes. Type 2 diabetes, really, what drives me crazy is, well, you're an impending diabetic or you're a borderline diabetic. Could you please explain to me what borderline diabetes means? It means to me, I don't have to do anything about it. So forget it. I can just watch the food, but I'll probably eat it because, I'm borderline, so it doesn't really matter. So I'm going to tell you, I hate the idea of borderline. No, you are diabetic and you are going to become worse if you don't do things that are right. That's type 2 diabetes. And so here you are, the cartoon on the side that says, it wasn't really insulin. You don't have diabetes yet. It's just a warning shot. So I'd like to say, if someone tells you, like your family doctor, you're an impending diabetic, that is the time where you better get on to the go about controlling the diabetes. And that would mean that you're a diabetic, but you just don't need insulin or metformin or Ozempic yet. Next slide, please. So type 1 diabetes is a totally different scenario. That is a very serious condition of where all of a sudden, it's usually with children, and all of a sudden they end up in a diabetic coma. That is when the pancreas does not produce enough insulin to control the body's sugar levels, and the sugar levels spike to a level that you can become unconscious. So those types of diabetics really also have to be controlled in the same way. And it's particularly difficult, but they all have insulin. So things like the type 2 diabetes where you have Ozempic, where you have metformin, those are not used in type 1 diabetics. Next one, please. Okay, so what are the symptoms of diabetes? Well, because we're older with type 2 diabetes, and these are mostly the symptoms of type 2 diabetes, but really for all diabetes, you're tired. Well, today that could be almost anything. One of the biggest ones is the frequent urination. You got to go to the pot all the time. You got to pee all the time, and always hungry. Sexual problems, well, whatever. Sudden weight loss, yeah, maybe that might be a positive thing, but not really. But the two biggest important things are frequent urination. You've got to pee all the time. The other is a wound that simply will not heal. I mean, you want to rule out that it's not cancerous or anything. And the other is drinking large amounts of water. You can't just get enough water. You're drinking it all the time. And for us as optometrists, I examine somebody's eyes and I give them a pair of glasses. And then 2 months later, they phone up and they say, these glasses you gave me are useless. I can't see out of them. My vision just seemed to go and it's really hazy. Oh, yeah. Well, that's usually a sudden change in vision. So vision is one of those. Now, vision is probably one of the most important senses, like a barometer in your body that tells you if something is wrong for two reasons. Vision is very sensitive to lack of blood supply and neurological impulse, so we should pay attention. So if all of a sudden you have a double vision, maybe you should pay attention to that. That's number one. And also, it's the only place when we look at your retina the back of the eye. It's the only place that we can look inside your body to see how the blood is flowing without cutting somewhere. So what happens to vision can be very indicative of other things going on in the body that people may not have noticed. Next slide, please, Heather. Well, we can quickly go through these ones, Heather. So if you want to just keep going through them, diet is probably one of the most important things. Complete eye health examination. And, we always say we should do 30 minutes, 5 days a week. Well, I don't know if we're going to do that. But sitting in front of your TV, watching, the sports right now, and Netflix after Netflix, eating potato chip and drinking Diet Coke or drinking Coke is probably not the best way to go. So changing your lifestyle, but you want to make it fun. Next slide. You can just keep going on these, Heather. Oh, here's one. So good old Santa Claus. Well, with all those cookies that he eats, I just wonder maybe if we should have a glucose monitor there just to see how his sugar levels are before we give him the next cookie. And perhaps maybe, I don't know, maybe we can give him a sticker for good performance. I have no idea. Or maybe some leafy green vegetables to chomp, like a carrot on his way over the seas. Now, this is what I want to tell you. This is kind of a sad story. This is actually a cousin of mine. And I got a call from him, this is a few years ago, and then all of a sudden his vision went blurry. Now, diabetes runs in our side of the family. And anyway, so he came in, and I'm going to show you his pictures. Well, I'm just going to tell you, my cousin died a couple of weeks ago. He died. He lost, first of all, his vision. He lost one leg, and they were going to amputate the other leg. And he simply, still continued to have a drink of whiskey every night before he went to bed, probably more than one or two, and ended up in a care home. And it was a sad case because it really didn't have to happen. So the next step, next slide, please. These are his retinas when he came in. Next slide. This is when I first saw him, when he phoned me. Take a look. This is the left eye. Do you see a problem? A mess. And you see the right eye? Yes, beginning mess. And we know when we get to this stage, which is really quite serious, we've had diabetes for some period of time. So it was a case of total denial. We tried everything and we couldn't save him. We couldn't save him from himself. Next slide. And you can see it again. You can see the swelling. Next slide. And then you can see the decreasing in swelling after the treatments of Avastin. And the next. Yeah, and he even got a steroid injection. You see, when you look at that, you see those gobs of white. That's what you see. And that lasts for some period of time. White spots everywhere. It's awful, actually. Next slide. So what is the future? Next slide. The future is this. It's in your hands. So what you have to do is really pay attention to your health. It is the one thing in life that you can't replace. So I think the most important things in life are those that are available to all of us, most of us, but we abuse. And I think the order of importance is like this: your health, your family, and time. Those are the priceless gifts that we've been given. And yet we spend our time and money on so many other things. That's all I have to say today. I hope that you've gained some information. And if you have any questions, please don't hesitate to ask me. I'm just going to go to the chat line right now, and we've got here.
Hello. All right. So if anybody has any questions, please go ahead and put those into the Q&A box. I do have a couple of questions here. So we had a look at a couple of those slides. So easy things we can do daily to make a difference. So reducing the cookies, or, doing your stretches or using some weights while you're watching TV. Any other simple things that we could do that takes maybe 5-10 minutes?
Well, I think probably the most important thing, really, is to, maybe it won't take 5 or 10 minutes, but that is to get every year get a complete eye health examination. We go to the doctor, check our blood pressure, blah blah blah. But if you are a diabetic, I think the most important thing for you is just to eat right, to exercise, to keep your A1C in the level it should. I just want to say that when you go to see your family doctor, because every 3 months or so they want to take blood from you and check it out, make sure you ask, what is my A1C? And if you can't remember that, just say, what is my average sugar level? And I want you to lock, if you get one thing out of this entire slide presentation, lock it in your brain, 6.5, and keep that there. And if you can stay at 6.5, you're good to go. You're not going to get your leg dropping off, your toe turning purple, or anything else happen, and you're going to keep your vision. So 6.5, that's all I want you to remember. So how to remember that is the acronym. Well, we get our old age pension at 65, so just put a dot in the center and say 6.5.
That's a good one. So common red flags that we should maybe keep an eye out for. You talked about kind of fuzzy vision.
Yeah, one of the first signs of diabetes out of control, of course, the symptoms of constant urination and really thirsty. But what will happen is that in terms of vision, it will be like amazing. You'll wake up one morning and your vision is so blurry, and as the day goes on, it's still blurry. It just happens. Like it probably is somewhat gradual, but people ignore things that are gradual. But one day you realize, you're driving, I can't see. It must be something wrong with those glasses that I got. The coating must be coming off or something. Oh, I get a lot of interesting things.
Okay, I'm going to be honest. I had a hard time in that presentation. There was a lot of discussion about needles going near my face. If somebody does need to get that type of care where they do need to have those needles, what can you do to help them calm down? Or how do you deal with patients who are very anxious about getting treatment?
Okay, well, all right. So, for example, when we see somebody, for example, they may phone and say, "Look, my vision has gone down the tubes. Like, really, I've got something going on here," and we see them. The first thing I always do is I show them the OCC. I show them the picture. Now, listen, I never want to say to somebody that there is no hope, because there's always hope. It's just a matter of how you look at it. Okay. So what I say, listen, the first thing we have to do is get things under control. We're going to send you off to the ophthalmologist. We're going to see what we can do in terms of various treatments. The next thing we have to do is work. You can't get to perfection overnight. You didn't get there overnight. It was a slow process of where we just didn't pay attention to our own health. So I'm just going to say the most important thing really is when we see people, we always want to give hope. I never believe there's such a thing as that you can't have hope. Sometimes when we have permanent scarring that has occurred and the vision will not come back, we have to think of different ways of getting around a handicap. And so it's like someone who loses a leg through something or another. Well, it's called reevaluating the situation, and now what can we do? We just don't want it to get any worse than where it's at. And so that's the whole thing. There's always hope. It's just that sometimes we have to change our picture of what that is. And so it's like somebody who's had a stroke. I mean, maybe we're not going to get the same functions that we've had before, but that doesn't mean that there's nothing that we can do about it. We sometimes have to just adjust things. It's almost like when you get to be my age, you can't see close up anymore. Darn. What do you mean? I have to photograph everything and blow it up so I can see it. Well, I got news for you. You might have to break down and get a bifocal or a progressive. You see, you have to change my picture. There we go.
Okay, last one. Yeah, you talked about a lot of different medications and a lot of different prices. So are a lot of these things covered by healthcare?
Yes.
Or is it out of pocket?
Well, the answer to that is yes and no. But for example, I was just talking to an ophthalmologist the other day. if you want Lucentis rather than Avastin because you think it's going to work better, you probably could pay the difference. But I'm not sure it's really worth it or not. Some people, it's like when you have cataract surgery done, you can just get the basic implant that is paid by the government, or you can spend $6,000 and get a multifocal, like a bifocal implant put in your eye. Is it worth the difference? It really depends on where you're coming from.